Thank you very much. Thank you very much for a kind introduction. I'm Dr. Kerry Chung, as mentioned, the postdoctoral fellow of the CHK Institute of Health Equity. Today, I'm going to give all of you a brief introduction of health equity. In simple words, it is to be healthy fairly across social groups in our society. I was invited to give this talk because, as Elsie just mentioned, health equity is the key theme of this year's Hong Kong SAC as the theme for the Timely Impact Award. We have two main objectives. First, we would like to raise the awareness of social entrepreneurs to incorporate the concept and practices of health equity and the concept of social determinants of health into their business models and service delivery. And second, through their work, we'd like to engage and empower the communities for capacity building, especially for the more disadvantaged communities, so as to identify and address the needs and the social and health inequalities existing in our society. To achieve the above two objectives, you must first have a basic understanding on health equity. But before we dig into what is meant by health and equity, first distinguish the difference between equality and equity. And I think this is a very typical figure. This is sometimes a little bit oversimplified illustration, but it's a commonly used illustration for differences between equality and equity. And as shown here, three guys want to watch a baseball game, right? There are three guys in the blue, the tallest, and the red, the middle height, and the shortest purple guy. If we do nothing to help them, only the tall blue guy is tall enough to watch a game, and the other two just get blocked by the fans, right? But now, if we have a chance to offer help to them, what should we do? According to the principle of equality, everyone will be given the same, treated in the same way. So each of them will be given one box here. So right now, it's a little bit improved because two guys can watch a game, but leaving the shortest purple guy behind, he still cannot watch a game. But the question is, why should we allocate the resources equally when we clearly know that they have very different needs, right? And it is possible for us to redistribute the resources so that everyone will be happy, everyone can enjoy the game by redistributing one more box to the shortest purple guy so that everyone will be happy. And they are more equal in terms of their achievement, not just by the resources we give, right? So health equity is about the need. We are distributing the resources according to actual needs rather than simply treating them equally regardless of their own background, their own situation. However, the reality is usually going to the opposite. In many societies with a high income inequality or wealth inequalities, the richest guy or the top guy here got almost all the resources. And the shortest guy is even more deprived of the basic necessities. He's all lower than before. So we should take some action to achieve equity instead of to widen the gap like here. And similarly, the concept is the same. You may find it hilarious if we give the same bike to the kids, to women, to men, and the disabled, as if one size can fit all. In reality, we should design the bike according to their needs. So you can see different sizes of bike, a small size for the kid, a medium size for the women, and a large size for the man. And also, you can see for the disabled, it's actually a specially designed three-wheeled bike and with a hand pedal because it can move the legs. So this is to achieve health equity by their needs. Okay, so when we can grasp the concept between equality and equity, we can put it in the context of health. So for health equality is about the absence of differences, variation and disparities in health across individuals. So this is about no absolute difference across individual. They have to achieve the same level of health no matter what. But for health equity, it is about the absence of systematic health inequalities that are deemed to be unfair, unnecessary, unaffordable. So in this sense, part of the inequalities, part of the health inequalities are indeed health inequities. And whether some inequalities, some observed inequalities is equitable or not, requires some moral judgment. So we need a moral value and social value behind to judge what is meant by inequity. And there are two broad types of equity. The horizontal equity means to treat the equals equally. And the vertical equity means to treat the unequals unequally, so as to achieve a fair and need-based distribution of opportunities and social determinants of health, which I will describe in detail what is social determinants of health later on. And the core value of health equity is about social justice. And you find a very keynote paper about health disparities and equity. It clearly states that the issue is about justice. And the underlying ethical and human rights are that all people should be valued equally, and every person should be able to achieve the possible optimal health status without distinction based on their background, including but not limited to race, skin color, religion, languages, nationality, socioeconomic position, and also the gender, sexual orientation, disability, and also geography, and so on. The many factors that maybe the background, but they should have the same chance and potential to achieve the possible optimal health. And you may find that very similar because it is indeed in line with the first two articles of the Universal Declaration of Human Rights. So you're right. This is about the right to health. Just because in this context we're talking about health, so it is the human right to health and the right to a standard of living adequate for health. Despite the growing policy and research attention, health inequity is still a global challenge. And this is the review report conducted by the Professor Sir Michael Marmot, a very well-renowned thinker and author, researcher in the field of health equity. He conducted several reports in many parts of the world, including the UK, the European region, and also the Pan-Americas, and more recently the Asian Mediterranean region. And also we will be conducting a series of reports in Hong Kong as well, which will be later on. But this is the example I want to pick to illustrate the concept of health equity. Because I picked the life expectancy because it is probably one of the most well-known health indicator that is easiest for you to understand. In many parts of the world, we observe a social gradient in health. And in terms of here, it is about the social gradient of life expectancy. And let's focus on the line within the light green dots first. It is about the total life expectancy, which means that it is the expected years that a person can live and can live. This line is plotted against the x-axis, which is the area level income deprivation, so the percentage of income deprivation across the districts in England. And what we can see is this slope. Back in the most deprived region, the total life expectancy is only about 73 years, but it's gradually going up to 82 for the least deprived, so the wealthiest district in the UK. So right here is indeed a 9-year gap across district in the UK. But what is more important, or even worse, is a steeper slope for the lower line within the dark green dots, which is about disability-free life expectancy, meaning that the number of years one can expect to live in good health condition without any form of disability. And you can see Of course, it's lower than the total life expectancy because in the later life, we must spend, usually we will spend in some disability. But for those living in the most deprived areas, there are only 53 years living in there are only 53 years living without a disability. But for the least deprived groups, they can live up to 70 years without disability. And in other words, if you take it as a proportion of life they can spend in good health, almost 30% of their life is spent in disability for those living in the most deprived areas, but only about 15% for those in the least deprived areas. And the absolute difference is actually 17 years compared to 9 years for the total life expectancy. So what makes the huge difference in the health differences? In this book, The Health Gap, Professor Sir Michael Marmot just mentioned, raised a very important question. Why should we treat people but then send them back to conditions that made them sick? And this question sets the scene clearly. It's not just about the health system, right? Because it's not just about to treat people, but rather, it is about the social conditions that have an impact on our health, range of social factors. And that's what we call the social determinants of health, the condition in which we are born, grow, live, work, and age. And let's watch a video for a further explanation on the social determinants of health.
Even before we're born, there are factors at play which influence our health and well-being. The conditions in which we're born, grow, and live can affect us and our health in different ways. We also react to them in different ways. Poverty, stress, lack of adequate housing, education, unemployment, and poor access to transport and nutritious food are some of the things that can affect our health and life expectancy. The World Health Organization recognises that health and well-being are strongly influenced by social, economic, and environmental factors known as the social determinants of health. The environments in which we are born, grow, live, work, and age can have stronger influences on our health than our genetic, family history, or behavioural risk factors. A person's social and economic circumstances affect their health throughout their life. The relationship between income and health is on a gradient. This social gradient means that even a little bit of wealth can increase your likelihood of being healthier. A stable source of healthy food, appropriate, affordable and secure housing, education and employment, relief from financial distress, access to transport and services, loving and stable relationships, and being able to make choices about our lives means we are less likely to experience chronic conditions such as diabetes, cardiovascular disease, depression, anxiety, and other mental illness. How we are treated by and interact with others also has a huge impact. Stressful circumstances over a long time that make people feel anxious or unable to cope, discrimination, racism, social isolation, or just being treated as less than equal, can lead to poor health. And the interplay between these factors and a person's socio-economic circumstances can compound the situation. Experiencing a lot of stress and feeling unable to change things can also lead to poor health. But as health...
Okay, we can just stop here because as the video just showed you, actually there are different levels of indicator social determinants of health, that social determinants that can affect our health. It's not just about our age or sex or genes that have an impact on our health, but a range of different social conditions, including the lifestyle factors and the social and community network and the social capital of our society, and also a range of different working conditions, including but not limited to food production, education, and work environment, employment, sanitation, and healthcare services, and now very important in Hong Kong, housing condition as well. And the more macroscopic perspective is also about the general socioeconomic cultural and environmental conditions that altogether shape our health. They are interact with each other in shaping our health. And with reference to the rainbow diagram I've just showed you, we can have a quick overview of the context of Hong Kong and see how these different social conditions can affect our health. And for the context of Hong Kong, we all know that we are enjoying a very long life expectancy. It's actually the longest over the world, with 82.2 years for the male and 88.1 years for female in 2019. Yes, it's ranked at top, surpassing Japan a few years ago. But at the same time, we are facing a series of challenges. We have a rapidly aging society with an increasing dependency ratio, and also the income inequality still remain high among the developed economies in the world, and we have a very unaffordable housing market at the moment as well. And also, the GDP share on the social protection is rather low when compared to other developed countries or economies. And especially for our healthcare system, although we have although the inpatient care may be universal coverage, but the primary care is still a way to improve so as to achieve the health protection and health prevention. And under such a social context, and despite the longest life expectancy, and we still observe a social gradient between income and self-rated health. And this is actually the data collected from the population health survey, the population health survey conducted by the Hong Kong government in 2014 and 15. And when we plot the percentage of people who rate the health as poor or fair against their individual, their household income, we can see a clearly it's not just about those at the bottom who are at risk, but a social gradient. The lower their household income, the higher percentage they rate their health as poor or fair. And what is the implication behind is that if we just target those at the very bottom, which we think that they are at the highest risk, this is true, but only part of the inequality will be mitigated if we target only the most deprived one, because even among the relatively wealthier groups, a social gradient still exists. But what we can do to also flatten the curve, I will show you a concept later. And it's not just about the self-rated health, because you may find it rather subjective, right? It is your self-rated health status. But for the more objective our health outcomes like obesity, frailty, and vulnerabilities in older adults, and the presence of multiple chronic diseases, which is multimorbidity, and also the anxiety and stress and other mental health illnesses. The previous local research also show the social gradient and the health inequities in Hong Kong. So all the evidence converge to support the presence of health inequities in Hong Kong, which all of us should be aware of the fact and think a solution on how to mitigate such inequalities in Hong Kong. Several social conditions has been identified as the key drivers of the social gradient of health inequities in Hong Kong. I just named highlight some of them because of the time constraint. And first, of course, the education. The educational opportunities vary across the socioeconomic ladder. And in the previous local research in 2014, the poor, the children from a poor family, which is defined as having low income and also a low living standard, have a markedly higher proportion of children who are deprived of a range of learning-related resources. Also, for the work and employment condition, we know that the lower skilled workers have substantially longer working hours. And you may be aware of that long working hours is actually of a health implication in terms of cardiovascular risk and cerebrovascular, so our psychosocial well-being in terms of anxiety and stress. Also, although we have launched the Hong Kong government have launched a statutory minimum wage since 2011, and it will be adjusted every 2 years based on the inflation rate, but the rate is indeed still among the lowest compared with a range of different developed economies. That's what, which makes them difficult to afford the basic necessities in life, and especially with the rising commodity price in Hong Kong. Third, of course, the housing and living environment. Hong Kong has the most unaffordable housing market over the world, and in terms of the median multiple, the housing price and average housing price is indeed more than 20%, 20 times higher than the annual household income. So it's just more than 5 is indeed classified as severely unaffordable, but we are still 4 times above this threshold, so it's very, very, very severe. Also together with the shortage of a public housing supply, which waiting time for public housing is still 5.8 years on average. The number of people who are living in the subdivided flats and also the homeless person keep rising over the past 2 decades. We're 0.171 up to 0.226 million people living in the subdivided flats between 2013 and 2020, and also like 3 to 4 times higher percentage of the rate of the homeless people in Hong Kong between 2007 and 2018. And all of these factors are, in terms of the housing affordability stress and the poor living environment, have a health implication on both physical and mental health. Fourth, aging is a global challenge, or especially in Asian economies, that we are facing a population aging and the increasing elderly dependency ratio. And is expected until 2036, there will be 527 elders per 1,000 persons of age between 15 to 64. So, which means that the burden of people in the working age is increasingly higher in the coming 2 decades, especially when the poverty rate among older adults is remain constantly high over decades. We also observed a rising labor participation over the past 10 years, and that it is a mixed implication. On one hand, it could be due to the financial insecurity in older adults because they no longer have income, but the commodity price is rising, so they have to sustain their life by contributing to the labor market. But at the same time, it may reflect a generally healthier population so that they can continue to work and contribute to the society. So, but in any ways, the good news is that we have an increasingly proportion of older adults with a secondary education or above, thanks to the 9-year free education launched in 1978. So presumably, the coming cohorts of older adults may have better health and digital literacy to manage their health. And of course, we have to help them to utilize those new resources, technology to manage their health. They still need our help. And fifth, of course, about the healthcare services. And despite the relatively equitable and capacious inpatient care in Hong Kong, because the inpatient care is covered by the public sector, 90% of it is covered by the public sector, but the primary care is largely driven by the private market, right? This is market-driven. When you go to see a general practitioner, you have to pay with a high out-of-pocket fees. As a result of the rather pro-rich primary care, so supposedly this is the first point of contact when people get sick or people want to get some health consultation advice. But because of the pro-rich and primary care, the access to the primary care is poor, and the continuity care is also of a lower quality. Although this launch of some voucher schemes or public-private partnership and also the voluntary health insurance schemes, the commitment and effectiveness is still mixed up till this moment. And of course, for the COVID-19 ongoing pandemic, it is indeed a test for the capacity and resilience of a society and the healthcare system, the social system. And sometimes we'll see from the news that the ethnic minority, those of the lower socioeconomic status, will be being hard to say. The construction worker have to have lunch outside, and when the social distancing measure just launched, and so some of the examples that the government or the community have to take into account the different impacts across the social ladder of their policy and measures. It's not just about the COVID-19 specific outcomes in terms of infection or mortality, but also the worry. Those of low status are more worried about their financial status during the COVID-19, and the increase of stress level is also stronger in those in the less educated. And prolonged school culture for children have a pronounced impact on their development, especially for the low-income families and those with special needs. And this is a figure that created by our team showing that a wide array of social determinants of health are actually closely related to health equity. So you may be aware of that when we assess health inequities are usually measured against income, education, or occupation because they are actually called a socioeconomic position, which vary across the social class, the gender, and also ethnicity or race. Because of this social stratification, we are exposed to a differential exposure to a range of pathways, we can say. So the first pathway is the materialist pathway. It's about the exposure to the access to the material circumstances, including the living and work conditions, also the food security, and also the behavioral factors like smoking, drinking, and sleep deprivation, and also sedentary lifestyle. And third pathway is the psychosocial factors, so the daily life stresses, like financial hardship or the burden of caregiving. And all this exposure will have an impact on the equity in health and our well-being. Of course, the health system and social cohesion can provide a safety net to the socioeconomic disadvantage if they're functioning well. But we should be also aware of the broader, wider structural determinants of health equities, which are the public policies, not just about the health policies, but also about public and social policy, the macroeconomic policies, and also the culture and social values. And I'm going to show you a video taking the example of the racism.
No matter the color of your skin, where you live, who you love, or who loves you, anyone can get cancer. But it doesn't affect everyone the same way. It's unfair and unequal. Where you live shouldn't determine if you live, but all too often it does. Meet Jenny and Marianne, best friends since elementary school. They rode the same bus and loved the same dance moves. Years later, both were diagnosed with breast cancer. They were devastated by the news. But research suggests Jenny has a better chance of surviving. Black women are 40% more likely to die of breast cancer than white women. Where people live, work, grow, and learn can greatly impact their cancer experience too. story. Due to generations of unjust discrimination, her community has limited or no access to those options. Marianne, like so many others, won't have a fair and just opportunity to prevent, find, treat, or survive cancer. The statistics tell a harrowing story. African Americans have the highest death rate and shortest survival of any racial group in the U.S. for most cancers. The cancer-preventing HPV vaccination rates among youth are lower in rural areas than urban areas. And research shows the LGBTQ community is likely to face greater barriers to care such as homophobia or transphobia, which can prevent early detection of diseases such as lung cancer. The list of disparities goes on and on. At the end of the day, access to quality care shouldn't be a privilege, it's a right. For Marianne, for Jenny, for all people. That's why.
Okay, this is the example of the racism, which is maybe more relevant to the European or the US context, but it's a good illustration of how the structural determinants of health have an impact on our health, because the social value and culture shape the racism in the society, and then with their racism, they have lower access to material and circumstances with food or with healthcare services like screening, and that in turn affect their health. And that's a good illustration of what we can, and this also can apply to Hong Kong if we switch the racism to the socioeconomic position as well. So it's similar in the illustration. Of course, the impact of health equity is not a cross-sectional. This is across the time frame, a life course. This is back when we are still in our mother, and the nutrition and the maternal status have an impact in our health at the start. And in the preschool and school level, there's about skill development and whether we have access to the training or the education opportunities will have an impact on the achievement in later life. And also even if we have attained education, whether this education can fit the occupational needs of the society is another question. So we need to have training and employment for the work that can contribute to society effectively. And for retirement, it's about how we can protect from the financial hardship when we have no more income. And all for life course is about the prevention and health promotion. So it's not just about to prevent disease, but to promote the health and well-being over the life course. And from Professor Sir Michael Marmot in his Marmot Review in 2010, there's 6 policy objectives, which is incorporated this life course approach. So first is to give every child a best start of life, and then enable young people and adults to maximize their capacity and control over their life, and also a fair employment, healthy living standard for all, important for all. And also sustainable place and healthy place in communities is about the social environment. It's no longer individual achievement, but the context. And also the health system, whether we can prevent ill health and also promote health. And we're calling the social gradient of health I've just mentioned, both in Hong Kong and the UK, about the life expectancy one. We can see a gradient of health. We would like to introduce a concept of proportionate universalism. So let's focus on this graph. So in the pink line, this is current baseline. So if nothing is done, then, and we take the most optimistic approach, the overall health improved, but the extent of improvement is lower than among the most deprived, the wealthiest. So actually, if we do nothing, the inequality will widen. And most of our existing social policy usually address and target the most disadvantaged social groups. So for the orange line, the improvement is substantial among the most deprived group. But for those at the relatively higher, because they have no longer entitled to the social welfare schemes in the society, so there's not much improvement. So huge disparities across here. But for proportional universalism, we propose actions to have a sufficient scale and intensity to be universal, but also proportionate, targeted to reduce the steepness of the gradient. So we should do more to the most deprived, but don't leave the wealthier left behind, okay? We still have to help them so that the whole curve, the whole gradient can be flattened, right? In terms of our recommendation, the most important one, which is related to the social enterprise challenges, is to engage the civil society, and not just about the academic institution like us, or the entrepreneurship center, but also the business sector beyond the government. We would like to engage a wide range of civil society to help tackle the health inequity issue in Hong Kong. And there's probably a role for social enterprise in mitigating the health inequalities and inequities. And this is in line with the recent movements of the ESG, the environmental, social, and governance. And they're calling for incorporating health into this framework. So for business, they start to realize the importance of health